normalize glomerular capillary pressure, reduce systemic hypertension, lower proteinuria, prevent scarring. So far, so good. Peperemuzzi went further to say that the reduction of proteinuria with an ACE inhibitor within 4 weeks from starting ACE inhibition predicts the long-term outcome. So the more you reduce proteinuria, the slower the decline in GFR. So far, so good. But now let's look at other evidence where it doesn't fit anymore. Start with the ACCOMPLISH study, comparing benazepril, an ACE inhibitor, plus hydrochlorothiazide to benazepril plus amlodipine. The amlodipine plus benazepril in blue had a better outcome. And if we look at proteinuria, there was no significant difference in proteinuria. So we had different outcomes now for the progression of CKD with no significant changes in proteinuria. Now, even worse, we have the on-target study combining an ACE inhibitor and an angiotensin receptor blocker that showed that if you combine the two, telmisartan and ramipril, you get maximum reduction in albuminuria and worse progression of CKD, the purple line. So now we have paradox whereby best reduction in proteinuria led to worse decline in GFR. And again, GFR was not measured, but estimated GFR. So you can't rely, because with albuminuria you can have reduction and protection, you can have reduction and harm. So albuminuria cannot be a surrogate marker. Let's try to understand how and why we have this paradox. And again, a meta-analysis of all the dual blockade studies, all showing improved albuminuria, all showing no change or worsening of GFR. Basically, the problem we're dealing with is we're dealing with an increasingly aging population of CKD. We're dealing with an increasing aging population of CKD who has atherosclerosis, who has arteriolar sclerosis, and may not have hyperfiltration and hyperperfusion. Instead, they have elderly, ischemic, hypoperfused, and hypofiltering kidneys. So now we have a different scenario. We have atherosclerosis closing the renal perfusion. We have ischemic glomeruli that need angiotensin II to maintain glomerular capillary pressure and to maintain filtration. So angiotensin II in the older atherosclerotic cardiovascular patient, type 2 diabetic patient, is beneficial. It's maintaining glomerular filtration. You take angiotensin II out. Instead of normalization of glomerular capillary pressure, you have drop in GFR with drop of proteinuria. Furthermore, if you have dual blockade, now you have more or less cessation of filtration, so the GFR fall, and you have also reduction of proteinuria due to decreased GFR. So I think unless we understand the pathophysiology of the progression of CKD, and we realize it's not uniform across the ages, 20-year-old with type 1 diabetes, hyperfiltration, hyperperfusion, 80-year-old with type 2 diabetes, hypofiltration, and hypoperfusion. Albuminuria doesn't help us. So once more, rest in peace, albuminuria as a surrogate endpoint in randomized clinical trial. And that's why the MHRA, that's why the FDA, that's why NICE in the UK do not accept albuminuria as a surrogate endpoint for the progression of CKD. So once more, as with creatinine, if you want to measure progression, measure progression. If you want to look at who reaches end-stage renal disease, longer studies, check and see who needs dialysis. Be careful with composite endpoints. In other words, doubling of serum creatinine, increase in eGFR, ESRD. Composite endpoints are statistically inadequate if the variables and the parameters you measure are interrelated. You cannot use composite endpoint. And for some reason, along with creatinine, along with albuminuria, we love composite endpoints as nephrologists. So get off the altar of idolatry and worshipping creatinine in randomized clinical trial and measure GFR. Get off the altar of idolizing albuminuria and stop treating albuminuria. Treat CKD progression. Get off this idea that albuminuria. And if you do, look at the patient. Is he young? I can increase ACE inhibition. If he's old, atherosclerotic, I may be doing more harm reducing albuminuria because I'm compromising GFR. And first and foremost, do no harm. Thank you very much.
Thank you, Professor Majid, for this elegant presentation. And I will ask if there are any questions or comments. Yes, please. Dr. Asim, please.
مفيش مايك يا عاصم.
مفيش مايكرو.
مفيش مايك. مايك. طب
هيجيبوا هاي في مايك.
Okay, if you say the question, I'll repeat it.
ده خلاص لي.
I will say very humbly that there are inherent problems in clinical research in nephrology in general. You have to gather very large number of patients in order to follow up them for an endpoint which you would accept. Or you have to have a small number of patients followed for decades in order to have your firm endpoints fulfilled. Another point is of major importance that the surrogate markers used are time point measurements. And I wonder if kinetic surrogate markers of significant validity, I mean, significantly associated with the firm outcomes, are used.
I'm sorry, what?
Pardon me?
I didn't get the last word.
Oh, yeah. If surrogate markers, which are firmly associated with known endpoints which you would accept, are used, and these markers are likely to be kinetic markers. We don't measure protein excretion right now, but we measure slopes of change of curve over a certain period of time. And we can lump the surrogate markers together and connect it better using multiple regression analysis methods to improve the outcome of research.
Okay, I mean, the point Professor Asim makes is that if you use them serially, if you combine some surrogate endpoints, you might be able to substitute them for hard endpoints. My argument is more, think critically of the surrogate endpoint. And there may be different surrogate endpoints for different patients. And in order for a surrogate endpoint to be valid, it has to be underpinned by a valid pathophysiology concept. And that's the whole point I was making.
Thank you, Professor Magid.
Yes, please, Doctor.
Thank you for your very interesting and provocative lecture. I have some exception, however. Both in primary glomerulonephritis, in lupus nephritis, whenever one reaches a complete remission of proteinuria, the end-stage renal disease becomes very rare, meaning that at least the disappearance of proteinuria has a very good prognostic significance.
And it's the same in nephrotic syndrome, as you would say. In any type of glomerulonephritis with nephrotic syndrome, partial remission is better than no remission and complete remission. So again, once more, different surrogate endpoints may be valid depending on the context in which they are measured. In type 1 diabetes, with hyperfiltration and hyperperfusion, perhaps albuminuria is a very good surrogate end marker. But we're seeing more and more studies in older patients with cardiovascular disease where ACE inhibition is doing more harm than good in spite of reduction of proteinuria because the pathophysiology is wrong.
Thank you, Professor Magid. In the new guidelines, the KDOQI guidelines about progression of chronic kidney disease, they insist that we have the patient receive ARBs or ACE, even if the patient has macroalbuminuria without the indication of the age. So this is guidelines to be modified because of this.
The problem with the guidelines, they're not age specific. And I think you have to be careful. Guidelines are guidelines. Guidelines are not dogmas. Guidelines are to guide you to make your clinical decision. And what I'm stressing today is that you have to make different clinical decisions based on different patients underpinned by different pathophysiology. So yes, give an ACE inhibitor to reduce proteinuria in a 16-year-old with type 1 diabetes. No, don't give ACE inhibition in a cardiovascular patient who's 70-year-old.
Second question, about the patients in an accomplished trial. Did they do some
Patient with what?
an accomplished trial?
Accomplished.
Yeah.
trial.
Did they do some analysis for patients who progress to end-stage disease who receive ACE inhibitor plus ARBs in proteinuric patients? Because analysis here was all patients. Some.
Yeah.
If we do some analysis for those, can we prevent or?
You can. You get into the post hoc analysis. You get into subgroup analysis, which is fine as hypothesis generating. Be careful of subgroup analysis, which are not powered to give you a definitive answer, but they raise answers, they raise questions for you to test further in a properly powered, properly sampled size study. So yes, by all means, subgroup analysis can give you clues, but all too often, we take subgroup analysis as final results. Subgroup analysis are hypothesis generating.
Thank you.
Dr. Magdi?
Yes, my professor. So according to what you have said, that we had and still having and should have some studies comparing low protein diet, low protein type, another group with ACE inhibitors, a third group with ARBs, fourth group with any antihypertensive drugs, just to compare all of these together. And until now, we didn't have this, or we have small studies. So what I'm going to treat according to the guideline, no more.
Yeah, but that's why we have these meetings, that's why we have these debates, and that's why we're teaching you critical thinking. Guidelines are not the Bible or the Quran. Guidelines
Agree.
give you ideas,
Agree.
give you recommendations, and mostly give you suggestions. All 90% of the guidelines for CKD are 2C and 2D. In other words, suggestions for you to think and decide for yourself. So critical thinking once more and decide for yourself. But I found really, really intriguing why GFR was never measured in any trial on ACE inhibition and up, except in the rain, in half the patients, therefore a smaller sample size. When I was advising the beam to do the beacon, I suggested to them to measure GFR, but it wasn't in the interest of the company because what they wanted to show is reduction of serum creatinine, increase in eGFR. And most nephrologists forget that eGFR is not measured through GFR.
Agree.
Thank you, Professor.
And
Thank
drug
you.
companies
I
interchange
think we are-
the two, and that is very dangerous.
I'm sorry, we are very short in time. Professor Magid can talk to you at any time. Thank you very much, Professor. The next speaker is Dr. Adil Bakr. Dr. Adil Bakr is working in, he is the head of the Department of Urology in Mansoura Urology and Nephrology Center, and he's very well known to us. He will talk about the non-immunological factors to preserve graft function. Dr. Adil.
Thank you, Dr. Sabri, for your kind introduction. I'd like to thank the organizers for their kind invitation to share with you this important event. My topic today is the non-immunological measures to preserve graft function. I prefer to start by a short background, followed by highlighting in some details different factors affecting late graft outcome before reaching the final part, which is the recommendations. There is achievement in the short-term outcome, either in patient survival or graft survival, but on the other hand, the long-term outcome is still suboptimal. So there is a lot of grafts are lost either due to chronic allograft nephropathy or distal function graft. The chronic allograft dysfunction is either alloantigenic dependent or alloantigenic independent, which is our topic today. I prefer to classify the alloantigenic independent factors to factors like types of grafts, tissue injury, inadequate graft mass, non-compliance, besides the important three factors, which is the post-transplant hypertension, dyslipidemia, glomerulonephritis, and other factors. So let us start by the types of the grafts. It is well known that not all grafts are equal. There is a living or diseased donors, and of known, living donors gives a better short-term for first or for retransplant. Moreover, living donation have a better long-term results. As regards diseased donor, we have either brain or cardiac disease donors, standard criteria donors, or expanded criteria donors. The 5-year graft survival rate was 81 for living donation, 72 for standard criteria donor, and only 52 for expanded criteria donors. As regards the tissue injury, it has an impact on short and long-term survival rates induced by brain death as a result from trauma or hemorrhage, which has an effect upon donor organs. So allograft tissues become primed. Organ removal, storage, and engraftments may increase graft immunogenicity, and so the upregulation of major histocompatibility complex antigens and cytokine adhesion molecules. So it has an influence in development of chronic allograft nephropathy. Ischemia reperfusion injury is a critical risk factor for early and delayed graft dysfunction and leads to ischemic ATN, which correlate with prolonged cold ischemia time in the older donors. As regards inadequate graft mass, it is associated with high risk of graft failure. A graft function survival in relation with donor kidney weight to the recipient weight. An interesting study where 1,200 recipients were enrolled having low ratio 2.3 gram per kilo, which was associated with increased risk of glomerulosclerosis, increased risk of proteinuria, and the increased risk of long-term graft failure. As regards one of the important issue, which is non-compliance, which is accurate estimation is so difficult, one of the important risk factors for graft loss, but there is a wide variety of studies, designs, and results. It has many causes. Among non-compliant, the risk of acute rejection was 4.2 times greater, and on the other hand, the risk of the graft failure may be 7-fold higher, and more with high white-collar occupations, long post-transplant period, non-married and anxious patients. The frequency of medications is one of the causes of non-compliance. It is so difficult to justify retransplant for those patients after graft failure in one study, while another retrospective study reporting similar allograft survival rate at up to 8 years for compliant and non-compliance. As regards post-transplant hypertension, which is frequent, having a negative influence on long-term patient and the graft survival, and the relative risk of allograft failure was 1.3 for each 10 millimeter mercury increase in the mean arterial blood pressure. In Mansoura study, we compared the different impact of post-transplant hypertension comparing normotensive patients before and after, sustained hypertensive patients before and after, and the worst case scenario was the newly developed hypertension, which has a very significant impact on 5-year and 10-year graft survival. Transplanted kidney may have a pro-hypertensive or antihypertensive properties. Inherited tendency to hypertension resides primarily in the kidney, and antihypertensive medication may be increased if a recipient from normotensive families received a kidney from a donor from hypertensive families. A mechanism of genetic factors predisposing to development of hypertension is not known, and it was presented in the morning session by Dr. Richard Johnson. Risk factors for post-transplant hypertension is long. I will stress on the steroid therapy and cyclosporin and renal artery stenosis. Steroids is not a major risk factor for chronic hypertension because of rapid withdrawal results in fall of blood pressure. Studies avoidance versus 5 milligram maintenance showed no difference in incidence of hypertension, while our study highlighted this difference. As regards cyclosporin is one of the predominant role of raising blood pressure with increasing systemic and renal vascular resistance, increased release of vasoconstrictive agents, and blood pressure will be lowered when shifting from cyclosporin to tacrolimus. Renal artery stenosis is evident between 3 months and 2 years. Risk factors include difficulties in harvesting, operative techniques, CMV, atherosclerosis, and delayed graft function. Diagnosis is by Doppler ultrasound and angiography, and improvement of the Doppler and perfusion after angioplasty. As regards dyslipidemia, it is frequent complication before or after transplantation, even with those with normal graft function. Immunosuppression often causes secondary dyslipidemia, and so regimens should be individualized to minimize the competing risk of acute rejection and the cardiovascular risk factors. A comparison between the study of Kasiski 2004 and Justin 2009, the incidence is less, and this is reflecting the use of statins. Different causes for dyslipidemia, including steroids, CNI, sirolimus, and secondary factors. Primary tacrolimus therapy is favorable than cyclo as it lowers the cholesterol and the triglycerides, and the Elite Symphony study reporting the low incidence of hyperlipidemia, hypercholesterolemia, hypertriglyceridemia with low dose tacrolimus. Very high triglycerides needing different management aids, and avoid fibrates due to myositis, rhabdomyolysis, and increased serum creatinine. Elevated LDL cholesterol levels in the ALERT study highlighted the effect of dyslipidemia management on cardiovascular disease outcome among kidney transplant recipients. And a meta-analysis including 16 studies, more than 3,000 patients, showed no significant trend towards the benefit of a statin in terms of cardiovascular mortality and non-fatal cardiovascular events, while the extension of the ALERT study for follow-up more than 6 years with 2 years utilization of a statin shows a significant lower risk of primary cardiac composite outcome. A statin were associated with decreased all causes of mortality, and early initiation of statin provides more benefits than late one. Elevated non-HDL cholesterol, which is the difference between total HDL cholesterol. It includes low LDL and lipoprotein A, and there is the elevation with triglycerides are linked to cardiovascular disease. Atorvastatin is a drug of choice. If no response, stop statin and start fibrates. The isolated low HDL cholesterol, 40 milligram, is an independent risk factor for coronary heart disease even after adjustment of LDL cholesterol level. Nicotinic acid, fibrates, and lesser extent statin may be beneficial. As regards the glomerular disease, the significant lowers the long-term graft survival. Relative risk for graft failure was 1.9, with high rate of graft failure at 5 years, value of native kidney biopsy, and important to differentiate with chronic allograft dysfunction. I prefer to classify to either recurrent of the primary GN or recurrent of secondary GN or de novo glomerular disease. Regarding the recurrent of primary GN, starting by IgA, recurs about 9 to 61% with approximately 33%, more frequent in younger patients with rapid progression, either immunopathological recurrence in a protocol biopsy or clinical recurrence in the event biopsy. Patients with IgA having HLA P8TR3 had inferior 10-year graft survival rate in comparison with those without these loci. IgA renal transplant patient had a comparable 10-year graft survival with non-IgA patients. IgA nephropathy recurrence was not associated with increased risk of graft failure. FSGS recurrence is 30% in the first graft and may reach up to 100% in retransplants. Early or late, relative risk of graft failure among children is 2.2 times higher than the recurrence in the adult. Follow-up up to 15 years showed no significant difference in graft survival between those with or without FSGS. Increased risk of recurrence with young age, mesenchymal proliferation, native kidney, mesenchymal proliferation in the native kidney biopsy, rapid progression to end-stage renal disease, pre-transplant bilateral nephrectomy, wide ethnicity, and genetic background. Circulating factors by abnormal colon to T cell may induce loss of nephrin, podocin of the glomerular slit diaphragm of the podocyte. Management is controversial. CNIs, plasma exchange, steroids, and rituximab may be beneficial. Idiopathic membranous nephropathy recurs about 30 to 40% after 2 to 3 years, maybe earlier or late, with comparable results with their controls. Trigger is the antibody against the podocyte protein. Symptomatic treatment or steroid cytotoxic agent and other immunosuppression has no convincing evidence of beneficial effect. Rituximab may be promising. MAPGN type 1 and type 2, it is a pattern rather than a disease. Recurrence ranging between 27 to 60%. Risk of recurrence may be marginal, higher in living donors. Recurrence in type 1 is deleterious effect on graft survival. Intensification of immune suppression may be hazardous, and cyclophosphamide MMF may improve the recurrence. Dense deposit disease, most patients have low C3, circulating autoantibody to nephritic factors. Successful treatment is a problematic. Plasma exchange rituximab might be helpful, and eculizumab, as just presented by Dr. Land in the Russian study, may be beneficial. Lupus nephritis, rate of recurrence between 5 to 10, reach up to 30 to 50%. Histological recurrence is a frequent, but lesions are rarely severe, usually do not impair long-term graft function. Henoch line nephritis, similar outcome to other renal disease, poor prognosis with extensive crescents. Histological recurrence is 78%, while clinical recurrence is only 22%. More frequent in children, outcome is more severe in adults, that leads to graft failure in around 10% of cases. As regards amyloidosis, it recurs frequently, but rarely causing graft failure. Chemotherapy and stem cell transplantation followed by renal transplantation in progressive AL amyloidosis, liver kidney transplant in hereditary amyloidosis, heart kidney transplant in severe irreversible cardiac and renal involvement. Colchicine is important, especially for FMF. Other secondary causes, light chain deposit disease, membranous nephropathy, 1 to 2%, reaches up to 5% at 10 years. 60% of them develop nephrotic syndrome not responding to steroids. Graft survival is the same as the control. This is unknown exact cause, may be a typical manifestation of acute or chronic humoral rejection, may be associated with hepatitis B or C. HUS, frequent in association with cyclosporin, but may be with TAC and sirolimus and even induction therapy. Risk factors include retransplantation, sensitization, CMV, parvovirus 19, and BK, and antiphospholipid antibody and malignancy. 1% to up to 15% in another study. It recurs weeks to years after transplantation. Clinically, is presented by acute graft dysfunction to mild increase of serum creatinine. Other causes, HCV related de novo membranous nephritis, or de novo anti-GBM disease, or sirolimus-induced de novo FSGS. What about the other causes? CMV positivity, BK virus presents with subacute progressive allograft dysfunction, diagnostic modality as discussed earlier in the morning session, gene polymorphism, cavelin 1, chemotaxis receptors, resistive index greater than 80% is associated with relative risk of graft loss. Other causes, hypercystinemia, and other causes including CNI toxicities, obstruction as evidenced by static MRU, and leakage as evidenced here by dynamic MRU. So what is the recommendations? Start a combination immunosuppression before or after transplantation is A1A. Induction therapy is also an A, either using interleukin receptor antagonist or ITG. Maintenance is preferred to be CNI antiproliferative prednisolone. TAC is the first line of CNI. MMF is the first line of antiproliferative. Emitor used after graft functions. Lowest dose of immune suppression if there is no rejection. Continue CNI rather than withdrawal of CNI. Continue prednisone rather than withdrawal. In CNI toxicity, you can reduce, withdraw, or even replace CNI with emitor if GFR above 40 and proteinuria less than 0.5 gram. Graft biopsy is indicated if graft function declines for unclear cause, if serum creatinine not reach basal after treatment, if expected kidney function is not achieved 1 to 2 months after transplantation, every 7 to 10 days during their graft function, with new onset proteinuria, with unexplained proteinuria. As regards the non-compliance, provide recipient family with education, and provide patient himself as increased risk of non-compliance with increased level of screening for these cases. As regards hypertension, measure blood pressure every visit, maintain blood pressure around 130/80, treat hypertension using any class of antihypertensives, monitor closely, and in cases with proteinuria, it's better to use ACE or ARBs as a first line. As regards dyslipidemia, measure complete lipid profile in all recipients with different frequency, evaluate this lipidemic recipient for secondary causes. In cases of elevated triglycerides, you must underline cause and adult with lifestyles and adolescents with lifestyles plus treatment. In elevated LDL, adult to keep a level below 100 milligram, adolescents to keep a level below 130 milligram. In cases of elevated triglycerides, non-HDL-C cholesterol with normal LDL, in adults keep the level below 200, and in adolescents keep the level below 160. Recurrent glomerular disease, screen recipient with primary kidney disease, focal segmental for proteinuria, daily for 1 week, weekly for 1 month, every 3 months for 1 year, and every year thereafter. The screen recipient was potentially treatable recurrence for IgA, MBGN, anti-GBM, and ANCA-associated vasculitis for microhematuria once in the first month, every 3 months in the first year, annually thereafter. Patients with primary HUS with episodes of graft dysfunction is screened for TMA, and if screen suggests treatable recurrent disease, graft biopsy is indicated. Plasma exchange if the biopsy show minimally changed disease of focal segmental. High-dose steroid and cyclophosphamide in recurrent ANCA-associated vasculitis or anti-GBM disease. ACE or ARBs for recurrent GN with proteinuria. In primary hyperoxaluria, suggest appropriate measures to prevent oxalate deposition, pyridoxine, high calcium, low oxalate diet, fluid intake to enhance mineral dilution of oxalate, sodium and potassium citrate, alkalinized urine. For obesity, assess obesity in each visit, measure height and weight in each visit, calculate BMI at each visit, measure waist circumference when weight physical appearance suggests obesity or BMI above 35 kilo per meter square. For lifestyle, patients are strongly encouraged to follow healthy lifestyle with exercise, proper diet, and weight reduction as needed. Thank you. معلش هو المدة بتاع المحاضرة 25 دقيقة، هو ظبط غلط على 20 فلسه 5 دقايق.
عندك حق.
ماشي.
أنا لاحظت القصة دي برضه.
معلش.
بس معلش عشان we are very short in time. We have 2 or 3 minutes for questions, please. Just very hot questions. That is good, very good. Thank you, Professor. Thank you, Dr. Ad. لا خلاص يا أحمد.
Professor Hala Al-Wakil, Professor of Internal Medicine and Nephrology, Alexandria University. The subject is Kidney Protection Program in Alexandria region. Please, Dr. Hala.
Please, Dr. Hala, be very strict in the time, please.
بسم الله الرحمن الرحيم. Mr. Chairman, ladies and gentlemen, first of all, I would like to thank the organizing committee who invited me to present this work. Also, I have to thank the ESNT who sponsored partly this work. CKD in the context of non-communicable disease is well-known fact, and NCDs, namely CKD, hypertension, diabetes, dyslipidemia, and obesity, are considered to be a major health problem. Just 60% of the global healths are caused by NCDs, and 80% of these deaths occur in our region, in the low and middle income countries. Moreover, more than half of these deaths occur prematurely. That's to say, it occurs before the age of 60, which is a productive age, and also these could be preventable. For that reason, the WHO established an action plan for 5 years, starting from 2008, to prevent and control this anemia. As regards the country profiles, what about our country? Egypt the deaths, the mortality in our country is made mainly more than 80% of these NCDs. Just less than 20% are caused by communicable, maternal, perinatal, and injuries. And 30% of our deaths occur under the age of 60, which constituted a great financial burden to our country. For that reason, this financial burden, as well as the exhaustion of the NCDs for the healthcare authorities. Moreover, the NCDs are easily preventable and controlled, as we said, and this could be prevented when they are early diagnosed. So the WHO established this statement that to prevent chronic disease is considered to be a vital investment. They concentrate not only on these animals, on these four main animals, the chronic respiratory disease, the cancer, the diabetes, and cardiovascular disease, and the last two are the main causes of CKD in our region. But they concentrate in the primary prevention of the risk factors, which are mainly for the tobacco overuse, the physical inactivity, the unhealthy diet, as well as the consumption of alcohol. For that reason, 6 objectives were held. First of all, to raise the priority accorded to the non-communicable disease, and to make this work integrated at a national and international basis, to strengthen the national policies for prevention and control and NCDs, to promote the intervention to reduce the main modifiable risk factors for NCDs, to promote research, and this is one of our issues, as well as to monitor these NCDs and their determinant, and promote partnerships with all organizations that are interested in that field. This is one of the modalities of cooperation between the WHO and our ministry in that field. Moreover, one of the success stories internationally was held nearby to our region, which is in Damanhur, which is a very success story in cooperation with the Sheffield Institute. So the idea of Keep Alex Calm, which is a screening program for non-communicable disease, namely CKD, hypertension, diabetes, obesity, and dyslipidemia, as well as the risk factors. To screen something, this refers to the detection of individuals with unrecognized or early stages of the disease, which is completely different from surveillance. And why screening, basically? Because it is an important risk factor when we are talking about CKD, and its prevalence is high when we are talking about early stages. It involves progressive loss of our kidney function, and when they are recognized late, in early stages, they can be diagnosed by very simple tests, and treatment could delay or prevent the progression. CKD screening programs around the world is not a strange issue. So for our program, we allocate a sample size of 2,000 personnel according to the sample size equation. And currently, we recruit 1,500 persons. And the personnel coming from the screened region, coming from 4 governorates around Alexandria city. This is Alexandria, Bahira, Kafr al-Sheikh, as well as Matruh. And these 4 governorates constitute the 3 categories of our patients: the urban in Alexandria, the rural in Bahira and Kafr al-Sheikh, and Bedouins of Matruh, which are well representative to the Egyptian population. These included subjects coming from the family members and the neighborhood of our medical students and house officers from Alexandria Faculty of Medicine, because Alexandria Faculty of Medicine geographically accept those people coming from these 4 governorates. And then to complete the sample size, 10 screening campaigns were done. The aim of these projects entail 2 aspects, the educational aspect as well as the screening aspect. As regards the educational aspects, more than 200 house officers and medical students were involved in this training. 4 educational workshops for sound, updated knowledge in the field of NCDs. Skill lab workshop for manual skills, for the venipuncture, for the blood pressure measurement. E-learning workshop for electronic skills for submission of the data electronically, as well as the general and transferable skills. That is a lot. Of these are the team working, the cooperation, the collaboration with various organizations, the confrontation inside our country, in Mansoura, in Cairo, as well outside in King Faisal Specialist Hospital and Research Center, the role modeling, the peer training and leadership for themselves as well as special skills as photographing, the brochure design, the training manual design, and also our students put a lot of future plans and dreams. They are dreaming to screen all Egypt, all the Arab world, the whole region of the all countries served by the Emiro, as well as the whole world. They are very enthusiastic, and this is one of the activity of our students.
So why get balance? Because prevention comes first.
Then comes the screening part. The screening part involves first the questionnaires, the history taking, the examination for body mass index, blood pressure measurement, as well as lab investigation for proteinuria, serum creatinine, blood sugar, cholesterol, LDL, and triglyceride. As regard to our risk factors in the screen, among the screened population, around 15% were smoker, and they were a long-standing smoker. The physical activity were not so bad, as well as the healthy diet also, it was almost healthy. The alcohol intake was almost nil. As regards the CKD, globally, among the whole sample, it constitutes about 2.5% in the whole population, but it is variable in some region than the other. Diabetes constitutes around 15%, the blood pressure around 20%, the heart attack around, and cardiovascular stroke was around 5%. The obesity were very high, around 65%. But there are very variable data among the different regions. For example, in Siwa, which is part of Matruh, the CKD was, I'm sorry, it was around 20%, but